Bismillah Rahman Rahim. Quote of the day: see the bad inside yourself and good inside the others. Today, the topic of presentation is health education. I am Dr. Rabbia Iqbal, PGR Community Medicine. I am presenting under the supervision of Professor Dr. Saira Afzal, Dean, Institute of Public Health, Lahore. Today, I am presenting the remaining portion of health education. So, learning objectives of today's presentation is contents of health education, principles of health education in Pakistan, program planning, Delphi and modified Delphi technique, barriers to the health education, and MCQs at the end. Learning outcomes. By the end of this presentation, participant will be able to understand about the contents and principles of health education in Pakistan, and barriers in health education. So, contents of health education include human biology, nutrition, hygiene, family health, disease prevention, mental health, accident prevention, and health services. Now we will discuss this one by one. First is human biology, include body and physical health, reproductive and family health, a healthy lifestyle. Body and physical health include basic anatomy and physiology of the body, importance of physical fitness and exercise, role of rest, sleep and balance activity, effects of alcohol, smoking, and drugs. Reproductive and family health include reproductive biology and safe motherhood, child spacing and birth feeding practice, child growth and development and milestones, immunization, and preventive child care. Healthy lifestyles include building positive daily healthy activity, household hygiene and disease prevention, importance of school-based health learning, nutrition as a part of everyday lifestyle. Second is the nutrition. Uh, so the objectives are promote balanced diet and healthy eating habit, remove food myths and misconceptions, improve nutrition knowledge in all communities. Issues addressed: incorrect weaning and feeding practices, improper diet for infant and pregnant women, unhealthy food distribution within the family. So the diseases that can be prevented are malnutrition, diabetes, cardiovascular disease, obesity, anemia, and vitamin deficiencies. Next is hygiene. Hygiene include personal hygiene, domestic hygiene, and community hygiene. Personal hygiene include bathing regularly, hand washing, oral and dental health, nail and foot care, and covering the mouth to prevent the airborne diseases and next is the domestic hygiene, which include clean home, safe water, proper ventilation, hygienic food storage and waste disposal, control of insect and pest and rodent. Community hygiene include community water supply and sanitation systems, solid and liquid waste disposable facilities, vector control, and safe house standards. Family health, role of family in health, first to model and promote healthy behavior, early identification and diagnosis of illness, care and support for sick family member. So the goals of the family health education include build self-reliance and reduce health dependency, improve child care and development, develop home-based self-care practices. Child care include nutrition from the birth onward, immunization schedule, growth monitoring and checkups. Home environment, safe water and clean food, good ventilation and lighting, emotional stability and support. Self-care include basic first aid knowledge, managing minor illness at home and knowing what to seek help. Next is disease prevention and control. Major diseases are included cholera, typhoid, malaria, tuberculosis and diarrhea. So cholera can be prevented by providing safe water and hand washing, typhoid by clean water and vaccine, malaria by nets and insecticide, tuberculosis by BCG vaccine and ventilation, diarrhea by hand washing and maintaining hygiene. So health education activities teach community about the disease transmission, promote preventive behavior, conduct community awareness campaign. Why education matter? Communities must understand why to change. Prevention is far cheaper than treatment. Behavior change protect entire population. So next is the mental health aims of the mental health education: maintain and promote mental health well-being, prevent mental illness and breakdown, build healthy relationship and social support, reduce stigma around a mental disorder. Risk factor include social and economic stress and poverty, family breakdown and domestic conflict, substance abuse and addiction, and rapid social change and uncertainty. Warning signs: persistent sadness and hopelessness, extreme mood swings and irritability, withdrawal from social activities, loss of interest in daily activities. So the critical stages of the life are after childbirth, first day at school, adolescence, career choice, marriage, and bereavement. Next is the prevention of accident. Accident include home accident, road accidents, and workplace accident. Common causes of home accident: fall from the height and stair, burn, scald from the kitchen, poisoning by the chemicals or the medicine, and it can be prevented by non-slip mats and stair guard, safe storage of chemicals, supervision of young children. Accidents, common causes: speed and reckless driving, drunk driving and impairment, not wearing seat belt or helmet. It can be prevented by road safety education, enforced speed and DUI laws, helmet and seatbelt campaign. Work accident common causes include machinery without safety guards, toxic substance exposure, fall from the scaffolding. It can be prevented by safety training and induction, mandatory protective equipment, regular equipment inspection. Next is use of health services. So barrier to access, lack of awareness about the available facilities, distance and transport and financial constraint, cultural belief and distrust of modern medicine. Objective of education: inform communities about the health facilities, encourage use of preventive services, improve communication between public and health authorities. So the services which are provided are immunization, maternal and child care, screening services, family planning, hospital services, and community outreach, which include mobile clinics, home visits. So next is the principle of health education. First is credibility. The message must be trustworthy, accurate, and consistent with established evidence. So the key point must be scientifically accurate and evidence-based. Communicator must be competent and well-respected, should align with the audience cultural belief and context. For example, vaccination advice carrier far more weight when delivered by a trained doctor than an unqualified person. Second is the interest. People engage only with the message that are relevant to their own felt needs and daily concern. Focus on the issue that the community itself identify as important, link health message to the current real problem in the community, relate content to every life and community concern. For example, dengue education campaign during an active outbreak attract a significantly greater community attention. Number third is the participation involve the community, build ownership, trust, and long-term acceptance of the health message. So the key point include involve people in identifying and defining their own health problems, include community members in planning and developing solutions. Encourage active participation in implementation and follow through. For example, holding community meeting to collectively discuss and solve a local sanitation issue. Fourth is the motivation. Without motivation, knowledge alone does not lead to behavior change or lasting action. Key point: two type of motivation: primary and second. Second is the secondary motivation. Primary motivation include basic human need, that is safety, survival, and hunger. Secondary motivation through praises and recognition and tangible reward. Stimulate positive attitude and enthusiasm toward the health behavior. For example, explaining the concretely how immunization protect a child motivates a parent to act immediately. Next is the comprehension. Health and message must watch the language, literacy level, and background of the target audience. Use simple and everyday language, avoid all medical terminology, use visual aid and demonstration and concrete example wherever possible, adapt content appropriately to the audience's educational background. For example, demonstrating how to prepare ORS at home is far more effective than using medical terminology. And reinforcement, repeating health messages regularly through the multiple channels ensure lasting behavior change. So the key point include repeat key message consistently across the several communication channels, use poster, radio, television, community follow-up visit, regular community meeting reinforce the important health behavior. For example, regular hand washing reminder displayed and announced in the school and community center. Next is learning by doing. Practical and hand-on experience builds real skills far more effectively than the lecture or theory. Demonstration are significantly more effective than verbal explanation. Role-playing exercise build practical communication and health skills. Hand-on training greatly increase the adoption of the new health behavior. For example, teaching mother to prepare ORS step by step at home, not merely explaining the concept verbally. Next is known to unknown. Always begin from the what people already know before introducing the new unfamiliar information. So sequence should be known to unknown, simple to complex. Build on existing knowledge and everyday lived experience. For example, discuss familiar fever causes before introducing the more complex concept of malaria prevention. Next is setting an example. The health educator must personally practice the behavior they teach in order to maintain trust. So the key point include educator must personally model all healthy behavior they advocate. Contradictory behavior by the educator immediately undermine credibility. Leading by example encourage the entire community to follow. For example, a healthy health educator advising community against smoking must not be seen smoking in public. Next is human relations. Genuine mutual respect and good rapport are essential foundation for effective health education. Be friendly, approachable, and genuinely good listener. Respect local culture, belief, tradition, and community participation. Positive trusting relationships significantly improve message acceptance. For example, building strong rapport with the community before introducing any new health practice or behavior. So feedback confirm whether the health message was correctly received and fully understood. Use question, group discussion, direct behavior observation, identify and correct any misunderstanding promptly and sensitively. Allow the educator to continuously refine and improve their approach. For example, ask the community member to demonstrate ORS preparation themselves to confirm the genuine understanding. So the 12th one is the leaders. Community leaders significantly increase the acceptance and reach of the health education program. Involve religious, political, and respected culture leaders in program. Leaders serve as a trusted, visible role model for behavior change. Communities are far more likely to follow one when respected figure endorse a message. For example, a religious leader publicly endorsing the vaccination leads to dramatically increase the community uptake. Next is the health education in Pakistan, which include federal level. The federal government supports provisional activity and set the national framework for health education, organized through the Ministry of National Health Services Regulation and Coordination, provide resources and funding to support provisional health education program, lead national health campaign and public awareness drive, provide planning and coordination support to the all provinces, set national health education policy guideline and standard. Next is the provincial level. Provincial health education cell carry out the health education at the regional level. Each province has a dedicated health education cell to promote health education. Cell provide health educator for major medical colleges and teaching institutions. Coordinate health promotion activities with NGOs and partner organizations. Produce and distribute educational material for public health awareness. Teach health education to the medical student and healthcare worker. Next is the hospital-based health education. Hospitals play an important role in health education for patient and community. They are not only a treatment center but also the health of, education. Benefit of the hospital-based health education: increase awareness of the early diagnosis and treatment, improve communication between doctor and community, strengthen community support for hospital program, provide education after discharge to prevent readmission, reach the wider community through the patient and their relatives. So hospital should organize patient education program, community awareness session, and counseling services. Next is the communication persuasion matrix, a framework explaining how communication lead to behavior change. The matrix describes the sequential step a person goes through from first encountering a message, health message to the actually changing their behavior. So first is exposure. The health message reach the target audience through the chosen media channel. Second is the attention. The audience notice and pay attention to the message. Third is understanding. The audience clearly comprehend the meaning of the message. Fourth is acceptance. The audience agree with the believe in the message and content. Retention. The information is remembered and stored over time. And six is the action behavior change actually take place as a result of message. So next is program planning. Components of program plan include every health education program must include the six essential components in statement of goal, objectives, method, resource and constraint, implementation plan, and evaluation plan. So goals and objective. Goals include broad is a broad statement describing the overall purpose of health education program. Goals may be short term or long term. Two types are generally formulated goals for overall program, goals for health education and promotion. For example, reduce mortality from cardiovascular disease by improving the lifestyle behavior in the target population. Objective. Objective should be specific, measurable statement describing the expected behavior change. Must include four elements: time frame, when the change will occur, direction of change, which is increase or decrease, magnitude, the amount of change expected, measurement method, how change will be assessed. For example, by the end of second month, the target group will exercise 4 times per week to reduce the weight by 10%. So this is the picture showing first define the educational issue, then describe the learners and determine the area of education and determine the goals and objectives. Determine format of instruction, then determine the mode of instruction and design the system for feedback. To produce prototype of program and then plot test, revise the program as needed and then implementation and evaluation. So the program management system, three key indicators are used to monitor whether a health education program is implemented effectively. First is time, determine whether that program activities are being completed according to the planned schedule. For example, all the training session conducted on time. Cost, assess whether the financial and human resources are being used efficiently without waste. For example, is the program staying within the allocated budget? Performance, evaluate whether the program activities are achieving the intended object and behavioral changes. For example, our targeted group adopted the health behavior promoted. So evaluation include formative evaluation and summative evaluation. Formative evaluation conducted during the program implementation. So the purpose is identify the problem and make improvement while program is still running. Allow course correction in real time. Key action include identify the and fix problem early before they affect the program outcome, adjust teaching methods and educational material as needed, improve delivery of the health message based on audience response. So, summative evaluation conducted at the end of the program purpose assess the overall success of the program, determine its full impact on community, and use finding to improve the future program. It measured overall program outcome and extent of behavior change achieved, determine the impact of the program on the target community's health, inform the design, planning, and improvement of the future health education program. So the level of health evaluation include level 1, which is activity, assess whether the planned activity are actually taking place. The second level standards, determine whether the activity meet the required minimum equality standard. Level 3, efficiency, assess how effectively time and money resource are being used. Level 4, effectiveness, determine whether the target population understand and adopt the health message. Level 5 is outcome validity, evaluate whether the program is solving identify health problem in the community. Level 6 is appropriateness, assess whether the program fit with the other program and benefit wider society. Next is Delphi and modified Delphi technique. Delphi technique, a structured expert consensus method for identifying the health education priority through the iterative question round. So the key point include identify priority health education topic for program and campaign, develop evidence-based health proportion strategy, design training program for health educator and workers, forecasting future health education need in communities. So the step includes selection of experts, health educator, public health professional, and program planner are selected. Second is first round of questionnaire. Expert provide open-ended question on the health problem or education strategies. Third is analysis of responses. Coordinator summarize and organize the responses into theme. Fourth is second round of questionnaire, which is expert review the summarized response and reconsider their initial review. And then is consensus formation after a several round agreement is reached on the most important issues. Next is modified alpha technique, a faster variant where the expert rate are predefined list of health topics rather than the generating ideas from scratch. Developing health education guideline, policy recommendation, selecting health promotion indicator for program evaluation, designing training curriculum for community health worker, prioritizing the behavior change intervention for specific population. So the step include the modified alpha technique is the streamlined consensus by starting a structured list rather than the open-ended input. First is preparation of the initial list, and then expert rating and feedback and summary result are compiled and shared back with the expert panel. And then second round of evaluation, expert reconsider and adjust the rating based on the group feedback. And then final consensus, the most important health education priority are identified and finalized. For example, ranking, vaccine awareness method, community meeting and school program and society media campaign. Next is a barrier in health education. Barriers in health education are the factors that prevent the individual or communities from understanding, accepting, and adopting health message and healthy behavior. In Pakistan, several social, cultural, economic, institutional factors limit the effectiveness of health programs. First is educational barrier, low literacy rates. Many people cannot read or understand the message material. Lack of knowledge about hygiene, nutrition, vaccine, and disease prevention. Limited access to the formal education, especially in rural and underserved areas. Next is cultural and traditional barrier. Strong traditional belief may oppose modern health practices, misconception about disease causes, treatment and preventive measures, resistance to the family planning, immunization, or maternal health advice. Third is the language barrier. Pakistan has a multiple languages, include Punjabi, Sindhi, Pashto, Balochi, Saraiki. Health message in Urdu or English may not be understood by the local communities. Translation gap reduce the effectiveness of national health campaign. Next is the economic barrier, include poverty, prevent people from following the health advice in practice, inability to afford nutrition, food, sanitation, or healthcare services, health behavior change that require resources that may income families lack. Access and infrastructure barriers include poor access to the health services, especially in rural and remote areas, shortage of trained health educator in hospital, clinic, and school, limited health facilities, transportation problem, and weak logistics. Gender barrier include social restriction may limit women's access to the health information and services. Women often lack decision-making power regarding their own health or child health. Female health workers are often unavailable for female patients in conservative communities. Communication barriers include technical language, poorly designed material make message hard to understand, limited use of visual aids, demonstration, or interactive teaching method. One-way communication fail to engage the audience or address their specific questions. Community participation barrier include program may fail if communities are not involved in planning, and lack of community ownership reduce the adherence to the health advice and program. Top-down approach without the local input are often culturally inappropriate. Next is the institutional barrier, weak health infrastructure and poor coordination among government agencies, limited resources for mass communication campaign and outreach program, shortage of educational material, audio, visual aid, and trained personnel. Next we come to the MCQs. MCQ number 1. Which component of health education specifically focus on body structure, physical fitness, and reproductive function? A. Nutrition education dealing with diet and food intake. B. Human biology covering anatomy and body function. C. Community hygiene related to sanitation system. D. Disease prevention addressing the communicable illness. E. Mental health education related to the emotional well-being.
B.
Yes, B is the right option. MCQ number second, which aim best represent the objective of mental health education? A. Eliminating all psychological disorder within the population. B. Promoting emotional well-being and preventing mental illness. C. Increasing psychiatry hospital admission for treatment. D. Replacing the counseling services with pharmaceutical therapy. E. Restricting social interaction among vulnerable group.
B.
B.
Yes, B is the right option. MCQ number 3, which principle of health education emphasize the message must be understandable for target audience? A. Credibility of the health educator delivering information. B. participation of community in program planning. C. Reinforcement through repeated communications channel. D. Comprehension according to literacy and language level. E. Motivation through incentive and external reward.
D.
D.
Yes, D is the right option. MCQ number 4, which stage in communication persuasion matrix occur when the audience remember the health message? A. Exposure to the message through media channel. B. Attention directed toward the message content. C. Understanding of the message meaning and purpose. D. Retention of information over time. E. Action leading to behavior change.
D.
D.
D is the right option. MCQ number 5, which element is essential when formulating objective in health education program plan? A. Clear specification of measurable behavior change. B. Detailed listing of medical treatment procedure. C. Replacement of goal with the general mission statement. D. Elimination of evaluation method for planning. E. Limiting program activities to the hospital setting.
A.
Yes, A is the right
A.
option. A is the right option. Clear specification of measurable behavior change. MCQ number 6, which type of evaluation is conducted while a health education program is still being implemented? A. Summative evaluation, measuring final program impact. B. Outcome evaluation, assessing disease reduction rate. C. Formative evaluation, identifying the problem during execution. D. Efficiency evaluation, analyzing financial expenditure. E. Appropriateness evaluation, comparing national policy.
C.
C.
Yes, C is the right option. MCQ number 7, which technique use repeated questionnaire among experts to reach consensus of health priorities? A. Case control method for epidemiological investigation. B. Delphi technique involving sequential expert feedback. C. Cross-section survey of community health behavior. D. Experimental trial comparing intervention outcome. E. Qualitative focus group discussion with participants.
B. B.
Yes, B is the right option. MCQ number 8, which barrier to the health education arise when communities rely on traditional beliefs that conflict with the modern medicine? A. Educational barrier due to the limited literacy level. B. Economic barrier related to poverty or income. C. Cultural and traditional barrier influencing behavior. D. Language barrier due to multilingual population. E. Institutional barrier involving weak health system.
C.
C. C.
Yes, C is the right option. MCQ number 9, a health educator visit a rural community and began by discussing common fever causes already familiar to the people before explaining the malaria transmission and prevention. Which principle of health education is being applied in this situation? A. Credibility by providing scientifically verified information to the community. B. Reinforcement through the repeated health message across the multiple platforms. C. Known to unknown by linking new concept to familiar knowledge. D. Participation by involving community member in discussion making. E. Motivation by encouraging behavioral changes through.
C.
C.
Yes, C is the right option. MCQ number 10. A poor community understands the importance of balanced nutrition but cannot follow dietary advice because they cannot afford nutritious food. Which barrier to health education is illustrated in this example? A. Communication barrier caused by the complex education material. B. Cultural belief due to the traditional dietary beliefs. C. Economic barrier result from financial limitation. D. Institutional barrier related to the weak health policies. E. Educational barrier linked to the limited literacy.
C.
C.
Yes, C is the right option. This is the answer key. This is the YouTube channel where the recording of this video will be uploaded. Thank you.
Thank you very much, Dr. Rabbia. Very nice presentation. And the good thing is that you have mentioned many important techniques and methods. How can we develop health education messages, including Delphi technique and many other things. And the best thing is about learning by doing, and the good examples has been presented, and that is a sequence of what Amna has presented yesterday, and today the sequence has completed, and very good presentation. Thank you, Amna and Rabia, for completing this sequence of health education. Thank you very much.
Thank you, ma'am.
Thank you, ma'am.